Okay, everyone. I apologize. I got an email. I'm glad I got an email. That's the purpose of the muddy points, is when I've left that information and you need clarification. So, poisoning and overdose, your text really doesn't go into it much, and I hadn't even realized that I didn't really cover it. So, I just put together just a few slides to go over just the basics of what you need to know when it comes to poisoning and overdose, just some general information. And then there were questions about CPR airway, so I just addressed that a little bit here. So, types of poisoning. Obviously, ingested or swallowed, absorbed, inhaled, injected. Absorbed is any exposure from toxins. Basics: remove the clothing, get them away from the toxins, flush the skin, flush the skin, and flush the skin. If any exposure, even like when it gets in the eyes, if you ever work in an ER, they'll have usually a room set up or something set up where you're doing flushing of the eyes, flushing of the skin. It's something that goes on for a long period of time. Ingestion, ingested or swallowed. Any substance that causes illness or death when eaten, drank, or absorbed in relatively small amounts. So there are several different managements, different drugs or treatments you might do. I just put on here the ones that every nurse needs to be aware of. Naloxone, which everybody knows as Narcan, but since NCLEX has gone completely to generic, you need to know the generic name. I will give you some of the brand names to help maybe when you hear it out in the workplace, but naloxone or Narcan is to reverse the effects of opioids. You need to give it in cautiously if they have cardiac irritability. It's the safest drug when you don't know what's causing the respiratory depression, especially if you suspect it's due to an opioid. You may have to do this when you have a patient post-op on a PCA pump and the respiratory rate gets very, very shallow, or if an overdose comes into the ER. You may have to repeat it. That's when knowing your half-lives or knowing how to look up information about the medications, having access to somewhere to look up the medications, knowing the half-life. So the half-life is really when the medicine reaches the halfway, like if it's going to peak, you take it and it has a half-life, let's say, of 6 hours. So it's 6 hours, half of the dose is gone, and then that half-life goes in half, goes in half, goes in half. So at 6 hours, you have 50% of it left. And then in 3 hours, then in half of that, 1.5 hours. Anyway, so when you reach that first half-life, so the drug has a half-life of 6 hours, but the Narcan lasts 30 minutes, so you may have to repeat the doses of Narcan if the half-life of whatever they ingested is longer. So they'll come out and they'll go back under. So it's something that may have to be repeated. Anytime I've given Narcan, well, it can be IM, usually it's IV. You're shooting this into the IV. What else? Does not work to reverse benzos. Flumazenil is the one that's given, but I'm just letting you focus here on the naloxone. But if they overdose on a benzo, this isn't going to reverse it, or they may overdose on an opioid and a benzo. Okay, enough of that. Digoxin immune fab. You may have heard it as Digibond. That's what you'll hear referred to. That's what they're talking to. The chemical name digoxin immune fab for digoxin intoxication. That can be accidental, like somebody purposely doing it, a child getting into someone's medicine, or maybe just dig toxicity because the renal function's down or the potassium was too low and it affected the digoxin levels and they became dig toxic. It is only You only give this when they're in shock or a cardiac arrest with VFib or VTAC, or severe heart block, second or third degree, that is not responding to atropine. Whenever you're given Digibond, Digoxin Fab, you always want to monitor the potassium levels. Syrup of Ipecac, that used to be, it's to induce vomiting after ingestion of a poison. I think that I'm pretty darn sure they still sell it over the counter. Used to be that nurses would be on hotlines and you'd recommend they do this. Now they say do not ever recommend for somebody to take this at home. Do not have parents keep it in their house in case a child gets into something. They call 911 and get them out of there. Syrup of Ipecac, the problem is the doses are given wrong or the wrong concentration, and it can cause severe problems. So they now is what you might give in the emergency room. If the syrup of Ipecac will cause them to vomit. So if they take a caustic, something like gas, anything that's caustic burning on the way down, you don't want it to come back up because it's going to burn again on its way up. So think logically through that one. And you never give it contraindicated if they're semi-conscious, unconscious, severely inebriated, they have seizures or shock, or they have an absent gag reflex. And that's logical. If it's going to cause them to vomit, you don't need somebody who doesn't have a safe airway to protect, that they're able to protect, because then they're going to aspirate and you have an aspiration pneumonia and a whole new problem. Acetylcysteine, you may have heard as Mucomyst. There's a few names for it. Mucomyst is the one I'm most familiar with, but it's acetylcysteine. If you see it on Kaplan, you see it on NCLEX, you need to know by this name because they're not going to give you the Mucomyst name, and that's for acetaminophen toxicity, or what we commonly know as Tylenol, but it's acetaminophen. Acetaminophen toxicity will shut down your liver. So it is imperative to bind that acetaminophen and prevent the intoxication. Has to be used with caution in the elderly, those with asthma, those with severe respiratory insufficiency, and because of the acetylcholines and the autonomic nervous system. I don't know if you remember about your cholinergics, but that's the reason for that, because you don't want the bronchospasms. It cannot be given when you also give activated charcoal, which is the next one we're going to talk about. Also, do not give in the semi-conscious or unconscious individual. Activated charcoal. Activated charcoal works by trapping or binding the chemical drug, whatever was ingested, and prevents it from being from being absorbed in the gut. So it is best given within the first 30 to 60 minutes. If they've also eaten, if they have food in their stomach, you want to give a higher dose because the food will affect absorption. It tastes terrible. It usually comes in a powder and you mix it up with water. If you work in ER, you're going to do activated charcoal. It's pretty gross. So you mix it up in water. It is charcoal. Looks terrible. Tastes terrible. So often you'll mix it with a juice or something to try to give it some flavor. Never mix it with milk, sherbet, or ice cream, because they will block the absorptive power of the activated charcoal, and you just defeated yourself. And you have to be careful. Somebody who's out, what you might do in the ER is you're going to if they're out of it, you're going to and you know what they took, or there's something, you're going to shove an NG tube down and put this activated charcoal right down into their gut. And then a little later, they're going to start pooping it out, and you're going to be cleaning charcoal. It's gross. If you haven't done it, you will get that encounter at some point in your experience as an RN. Okay. Sometimes somebody might vomit initially if they're awake and you give this to them. If they do vomit right away, you want to repeat the dose, because it obviously hasn't had time to absorb anything. There's another precaution. Oh, Ipecac. If you need to give Ipecac and you also need to give activated charcoal, you want to do the Ipecac first, let the vomiting finish, and then give the activated charcoal, because you don't want to give both and have them vomit all the charcoal, because then again it hasn't been able to do what it's supposed to do and bind those drugs. Inhaled carbon monoxide and cyanide. Your book actually mentions the cyanide, but it doesn't really go into why that's an issue. Carbon monoxide we always think of in fires, or if they're have a wood burning stove, things like that. Carbon monoxide can build up inside and it can cause a poisoning. It will cause severe respiratory suppression. Oh, I put this in the wrong place. That headache, nausea, fatigue is supposed to be, well, actually, it falls under both. Both of them cause that. But really, the carbon monoxide, I did mean to put the headache, nausea, fatigue up there. Cyanide is not as easy to figure out. It has those same things, but they can also get very flushed. They may feel faint and anxious, dyspneic, tachycardia. So it's really difficult to know. If somebody has been in a residential fire or very closed area, you always want to suspect cyanide poisoning. I think it was late 80s. I'm not sure if your text mentioned when it was. I don't think it does. Anyway, the cyanide poisoning, what they've found with all our chemicals now, if there's any polymers that you'll find in wool, silk, paper, plastic, which is in homes, those items, when they're burned, they release a hydrogen cyanide. So then that gets inhaled by the individual in the fire. And I said we always look for carbon monoxide poisoning, and there's been cases where the cyanide poisoning was missed. If you see any soot around the nose or the mouth, you always want to suspect the cyanide poisoning also. With carbon monoxide, the management is 100% oxygen. 100% oxygen, because carbon monoxide, or CO, one oxygen molecule to one carbon. Okay, so carbon monoxide, or CO, will bind to the hydrogen, to your hemoglobin, where you're taking the place of your oxygen. So the way to combat or reverse carbon monoxide poisoning is long periods, long, like over an hour, 100% oxygen to replace those carbon monoxide molecules that have attached to the hemoglobin, replace it with the oxygen molecule. The cyanide poisoning, the 100% O2 isn't going to help them. Very difficult to detect. There is no test, or there is a test for cyanide poisoning, but it's not a local thing. It's not something you're going to get results of right away. So with the carbon monoxide, you draw a blood level to get a carbon monoxide level. It has to be at least an hour after smoking a cigarette, because there actually is carbon monoxide inhaled when you smoke a cigarette. With the cyanide, because they don't have access to the blood test checking for cyanide, it's not a simple thing. They have found that they can do a lactate level when the body is exposed to cyanide. It goes into an anaerobic metabolism, which releases lactate in the blood. So if they have a lactate level greater than 10, you should manage them, treat them for cyanide, and there's some drug management, but that's beyond what you need to know as a registered nurse. Just knowing what you're looking for, what the symptoms are, how you as a nurse would work for assisting in that management, and your goal is preventing neurological damage and making sure it's properly diagnosed. Next slide. Injected, simple, I put sting. Of course, you can inject drugs, but then you're going to deal if it's opioids or benzos or whatever. So at this point, we're just going to talk about If they get stung by a wasp, a bee, or something, if the stinger's still in, removing the stinger, washing the wound, putting cold on it, watching for anaphylaxis. If they are anaphylactic, the priority, of course, would give them epinephrine to prevent anaphylaxis. So if they're having a respiratory issue and they've been stung by something, your very, very first priority, although more than one person in an emergency room is going to be addressing this person, the first priority is getting the epi in, because you have to keep your airway, and then pull out the stinger. Okay. Now, CPR. There was questions about drowning victim. How do you know the air was obstructed? How do you manage the airway? Why do you do chest abdominals? So I just did some basic review here. The ABC, airway, breathing, circulation. Now, of course, when you take CPR, they're focusing on circulation. Check your pulse. Now, think of that as being out in the public, that they want to get emergency people there as quickly as possible. They want to defibrillate as quickly as possible. So that's why the focus has become on circulation. So thinking as a registered nurse in an ICU, on a floor, in a unit, in the OR, in a situation where you already are in the medical scenario where you have things available, you're focusing on your ABC. So you're hitting the button or calling a code or doing whatever. First thing is open the airway. Now, focusing on drowning. I put here the basics of basic life support include airway obstruction. So we always think of airway obstruction as being somebody choking. But multiple things can obstruct your airway. So if the airway is obstructed, you're going to know when you position them. The head tilt chin lift, I put things on here. If you suspect a neck injury, I put when. Of course, if it's a trauma, if it's unwitnessed trauma, the head's in a funky position. A drowning often will hit their head on the ground, the bottom of the pool. They may have hit the bottom of the lake, something like that. And so if you suspect or not sure if there's a neck injury, you're always going to chin thrust. I just put the two pictures here. I mean jaw thrust, not chin thrust. So anyway, this is your blocked airway, opening your airway with your head tilt chin lift, or the jaw thrust if you have to keep the neck immobilized. This is just basic review. You try to put in air, you reposition. If it doesn't go in, you're not seeing the chest rise. It's not going to do you any good to pump around, do the compression. So here are just the basics. You do this with abdominal thrust as you would if somebody choked. I'm not going to sit here and read the slide to you. It's self-explanatory. I hope it just clarifies. If you have questions, if you were stuck on things, one more slide. Here, rescue breaths, when to give rescue breaths, why to give rescue breaths. And I again apologize for leaving out some of this information or not being clear enough. And I hope this works to clarify and help you feel more prepared. And that's the end of my presentation.